good afternoon. Or almost afternoon. I'm Mike Soul. I'm director of the headache program here at U of L. My background is both adult and child neurology, and about 12 years ago I joined the university and decided to start a headache program. So I actually see adults 2 days a week and children 2 days a week, and 1 day a week do administrative and research and all that sort of stuff. So today we're going to talk about migraine headache in the workplace. So since it's a small group, you know, I tend to be an informal person, so if there's a question or anything, raise your hand or what have you. So from the American Migraine Prevalence and Prevention Study, we know that migraine is a common problem. It occurs in about 12% of the population ages 12 and older in the United States. It disproportionately affects women more than men. I see we have, I think, an all-female crowd. So it's about 3 times more common in women than men. It's most common in the midlife, so in the peak productive years, basically 25 to 55 year age range. And the rates decrease after about age 60 or so. So about 1% of the people in the United States experience chronic migraine, which equals about 1.5 million women, more than 500,000 men who experience migraine more days than not. So chronic migraine is 15 or more days per month for going on longer than 3 months. So some of whom live with migraine every single day. So depression and anxiety are about twice as common in people who have migraine compared to those who do not. Even more common in people with chronic migraine. About half of people with episodic migraine, so episodic is ever so often attacks of migraine. About half of people with episodic migraine have nausea with their headaches half the time or more. About 20% of people in the database have tried opioid narcotics, but it's associated with many problems. Opioids are not very specific to migraine and tend to cause other sorts of fallout problems. So who gets migraine? So as I mentioned, it's mostly women. It's about 20% of women get a migraine at one time or another during their lifetime, so 1 in 5. So that's about 4 or 5 out of this room. So migraine peaks during the peak productive years, so 30 to 60 years of age. It's disabling, some miss work, school, other activities. Many have reduced productivity during their attacks. So there's not just absence from work, but there's reduced productivity, which is hard to measure from any outcome. So how do you know you might have migraines? So symptoms that are associated with your headaches, migraine is typically one-sided. It's typically moderate to severe pain, throbbing pain, pain aggravated by routine activity, may be associated with nausea or vomiting, is often associated with an aversion to light or sound. So sensory stimuli tend to be kind of problematic for individuals who are having a migraine attack. So the notion, and this is a screener for migraine that was developed probably 6-8 years ago. The notion is that you check 3 or more of these yes boxes, then you probably have several of the diagnostic criteria for migraine, and then you should maybe talk to your doctor about making a diagnosis and then therefore treating the migraine headaches. So what is migraine? Migraine is a clear biologic disorder. It's like asthma, diabetes, or hypertension. It's a disorder of the CNS, so the central nervous system. So it's characterized by hypersensitivity to specific triggers or stimuli. Often there's a familial or genetic component, and there's a disorder of the nerve vessels in the brain and the blood vessels that surround the outside of the brain, the coverings of the brain. So why does one get migraine? Well, neurons in the brain, the nerve cells, are activated by a mechanism that's not well understood. We do understand sort of triggering factors for migraine, but we don't necessarily understand how those triggering factors then relate to the actual biomechanical mechanism of migraine. So this in turn then leads to a cascade of secondary events leading to release of inflammatory substances. So that's why anti-inflammatories over the counter often work in some people with having a migraine attack. Inflammation of the blood vessels and the surrounding tissue on the outside of the brain, and then activation of the pain pathways more centrally. And I won't go into neuroanatomy and things like that. But so what type of doctor should you see? Well, of course, everything should sort of start with a primary care physician. That's typically a family physician or an internal medicine specialist, or in the case of children, maybe a pediatrician. You ask maybe for a specific headache appointment and try to get a specific headache diagnosis. So headache is a is both a field of interest and specialty, but it's also a complaint, right? It's not a diagnosis, it's a complaint. It's like saying I have fever. What's my fever being caused from? So you may need referral then from a primary care to a neurologist, and neurologists see headache. It's probably the second most common complaint in the pediatric age group, probably the most common complaint to a general neurologist in the adult age group. So headaches are frequent and difficult to manage, or if there are other medical conditions, to manage simultaneously. So for example, some people have asthma and headaches. Some people might have epilepsy and headaches. Some people might have essential tremor and headaches and migraine headaches. So knowing all of those conditions and putting it in the proper context is important. So sometimes patients then need a referral from a neurologist to a headache specialist. So headaches are severe and disabling, may need a referral. So if they're not getting appropriate treatment with a neurologist, then not responsive to routine care, or there may be other existing medical conditions that make the treatment plan more complex. So that's sort of the part of the method of my madness is starting a headache program at U of L. Is, you know, we've got the resources here. I'm frequently co-managing with any specialist from OB-GYN to neurosurgery to psychiatry to we have it all in one place. So what should I tell my doctor about my migraine attacks? Well, how long have you had the headaches? How frequent? How disabling? When did they start? So for example, you know, occasionally I'll see somebody and they're having a headache that day. You don't have to have a headache that day. It's based on historic grounds. There's you want to kind of have some idea of the outcome indicators like frequency, severity, intensity, associated symptoms, things like that. What happens when you have a headache? So that helps to a physician to some extent. For example, and I, you know, I'm an academic physician, so I teach anywhere from students to residents to giving community-based talks or things like that. But yesterday I was talking to the residents. So migraine tends to send people to bed, basically. When you have an attack of migraine, the first thing you want to do is lay down to try to get rid of the pain. Other headache types, there's a less common type called cluster, where an individual tends to be restless and agitated and they want to walk around. So that gives us some information about what the headache type might be. So who else in the immediate family gets headaches? So it turns out that migraine occurs, often runs in families. So 70% of the time we find a first-degree relative who also has migraines. So father, mother, sister, brothers, first-degree relative. Are there other headache types in the family? What might cause you to get a headache? So for example, drinking alcohol. Red wine is often a trigger for migraine. Too little sleep, stress, missing meals, and thank you for lunch, and I've got mine to take with me. So what else will the doctor need to know? Well, what medications do you take now? What have you tried in the past? So for example, if you're being referred to a tertiary care academic facility, you probably have tried other medications, either over the counter or prescription, for two purposes for migraine. One is for acute relief, as needed relief. The other is for preventive relief. So what kind of, that's the type of information that you need to gather when you're seeing a person about your headaches. What other medical conditions have you had? For example, head injuries, depression, weight problems, other coexistent medical conditions, whether they be comorbidities. Comorbidity means occurring simultaneously with another condition, like asthma is a comorbidity, occurring more frequently. If you have one, you might have the other more commonly. Or just coexistent medical conditions. You happen to have irritable bowel syndrome or something else as well. So what kind of treatments help? And when I talk to patients about treatment of migraine headaches, I talk about acute treatment and preventive treatment. So the notion is that acute treatment is what you take on an as-needed basis. So when you have a migraine, you need to take something as needed. That's called acute treatment. So it treats the pain depending on how specific the medication is, it may treat the associated symptoms of migraine, the light, sound sensitivity, the nausea and vomiting, particularly with a class of medicines called triptans. And then there's preventive treatment, which is typically taken on a daily basis, doesn't work right away, but gradual reduction in frequency, severity, duration, maybe even improved response to the acute treatment. So that's the goal of a preventive strategy. So those are the sort of two main arms of treating migraine. Then behavioral approaches. So, lifestyle changes. Nobody wants to make lifestyle changes, but I'm on a weight loss diet. I'm gonna have to eat only about half of what's in the box. But limiting caffeine and other triggering factors, reducing stress, exercise on a regular basis, regular sleep, and in some instances counseling or psychotherapy, biofeedback, and relaxation techniques. So biofeedback is essentially administering relaxation techniques in the context of giving the individual person feedback on those variables that might not otherwise be considered to be under conscious control. So for example, one cannot normally influence their heart rate, but if you are guided to reduce your heart rate, then you can reduce your heart rate by 5-10 points or something. And it turns out that that's associated with improvement in migraine control. Sort of eating regularly is important, so skipping meals. Some people have a migraine when they skip meals, so eating on a regular basis is important. All things in moderation, I keep telling myself. So are all migraine medications the same? So migraine medications can all be different and work differently in the brain, different parts of the brain. Many patients need both an acute treatment and a preventive treatment. Some of the common examples of acute treatments would be a class of medications called triptans. The most common example is sumatriptan, which is trade name Imitrex. But there are many different examples of the triptans, and they may work at the same mechanism of action, but they have different routes of administration, different half-lives, and so choosing a triptan is important in concert with your physician. Analgesics, so many patients, most people already tried an analgesic over the counter, but an analgesic is a medication that's a standard pain reliever over the counter. Preventive treatments are often selected in the individual according to what coexistent medical conditions they might have or comorbidities, conditions that occur more commonly in individuals with migraine. So how do you know which type of treatment is right for you? So acute is, there are individuals who just simply take an acute treatment for their migraine attacks. So that works most commonly if the individual has infrequent attacks. They tend to be shorter duration, may not impact routine functioning. So acute treatments, the sort of best that we have works in about 30-45 minutes. Onset of relief of various measures. And the ideal drug, of course, would have no side effects, not cost anything, and you could take an unlimited supply. But there are certain things to know about acute treatment in terms of potential side effects and things like that, and it depends on which medication is being prescribed. So preventive treatments are often prescribed in the context of frequent migraine headaches that cause disability, so individuals who are having frequent attacks, and it kind of depends on opinion as much as anything else, but at least 2 attacks per month, that probably justifies preventive treatment depending upon which treatment you're discussing. And then recurring headaches that significantly interfere with daily activities, so job loss or absenteeism, reduced productivity. Overuse of acute medications, so it turns out that chronic migraine is strongly associated with what's in the past been called rebound, or most probably appropriately termed medication overuse. The notion is that there's a strong association between frequent use of acute medications and chronic migraine. And then sometimes acute medications are either not effective, not well tolerated, or they're contraindicated. And of course, the decision about preventive medication also in migraine also depends on the severity or degree of disability during the attack. So for example, I have a few patients that do things like, I have a truck driver and he develops an aura with his migraine. An aura is a specific visual, sensory, or speech disturbance associated with migraine. And he doesn't have them frequently, but he has maybe 1 or 2 a month. But half of his visual field is lost. So if you can imagine looking at me and the right half of everything that you see is black, it's not good for a truck driver. So, and it occurs maybe while he's driving a truck. So that might justify putting him on a preventive strategy. And so those are the sorts of discussions that you have to have. And then behavioral treatments can always be used. So what can you expect from acute headache treatment? Well, acute medications should work within a couple hours. Now, do we have something that works instantaneously? Well, no, not really. There's various shots and things like that, but they don't necessarily work faster. The best that we can do is usually within 45 minutes or something like that. This particular set of slides talks about 2 hours. It does improve the response if you take the medicine early. So for example, some individuals who have migraine get maybe some non-specific symptoms that occur within an hour or 2 before the onset of their migraine attack. So excessive thirst, GI distress, mild cognitive dysfunction, things like that, that might signal the onset of a migraine. And that's when you should take the acute medication. So you might be targeting decreased pain, nausea, vomiting, light and sound sensitivity. And then you always want to kind of get instructions from your physician about when do you take the rescue medications, what side effects might we expect with these medications. So what can you expect from a preventive treatment? Well, preventive treatment doesn't really cure migraine, but it can reduce frequency of the attacks anywhere from 20 to 60%, or sometimes even much more dramatic than that. It can reduce the severity of the attacks, improve the response to acute treatment, and reduce the use of acute and rescue medications. So preventive treatment, whereas it doesn't instantly work, it's a longer term view, it might make things better down the road. So you need to give them medications for preventive treatment adequate time, typically 2 to 3 months, to fully evaluate. And you evaluate preventive treatment of migraine by keeping a headache diary. So that's the outcome measure that we're looking for, is a diary, and there's a standardized diary. At the end, I'm going to show you a website for it's pretty easy to remember. It's ACHE, A-C-H-E, American Council on Headache Education. Headache specialists are not particularly creative. But keeping a headache diary provides that feedback that's necessary in terms of frequency, severity, response to treatment, duration of attacks. These types of things are important to keep. Then improving treatment success, being proactive in seeking help, of course, is important with about any medical condition. Understanding your headaches so that you can appropriately communicate with your provider. So doing some of your own sort of homework is important, because as we all know, when we see the doctors tend to speak in Latin and things like that. Maybe you can pick up some Latin from your perspective, but the other thing is kind of just getting in the right framework of what can I expect with the migraine attack, light, sound sensitivity, all that sort of thing. Discussing what are the goals. So migraine, as far as we know, is probably genetic, but it's eminently modifiable by these management procedures that we've discussed. Then developing realistic expectations. If you've had them for 20 years, they're probably not going to go away anytime soon, but in fact they can be modified and improved dramatically. And then working closely with your provider and following instructions. So asking for specific instructions on when you take each medication, how you take it, understanding side effects, taking only medicines that are and dose that are prescribed. So if there's an issue with medication overuse and rebound, avoiding the over-the-counter type medications as much as possible. Accounting for the headache, so keeping a headache diary, recording the medications, monitoring response to treatment, that's important. That's participating in your own care. Then following treatment plan, taking medications only as instructed, monitoring the lifestyle factors, exercise, diet, medications, things like that. So can lifestyle make a difference? Well, yeah, it makes a difference. You were probably having lifestyle problems leading up to the worsening of migraine, and then parsing out those different variables and maybe improving them is important. So triggers can be controlled or recognized. So too much caffeine. So caffeine has this paradoxical relationship to migraine. Caffeine is contained within many medicines that are used to treat migraine as needed. So Excedrin migraine contains caffeine, and it's okay to use brand names if I'm not talking to other healthcare providers. But Excedrin migraine, which by the way, Excedrin migraine, Excedrin tension type headache, Excedrin back and body, they're all the same thing. You peel off the label, open up the pill, it's all the same stuff. It's just marketing. Sleep deprivation or changes in sleep patterns, any way that you can regulate your sleep. So there's pharmacologic methods, but there's behavioral things to sort of slow down and analyze too. If you're watching, for the kids that I see in particular, if their parents are letting them watch, horror stories before going to bed, that's not a good thing, and they probably won't sleep well. So things like sleep deprivation, everybody experiences some change in their sleep pattern. So next month's talk on sleep is important to come to, not just from a migraine standpoint, but from an overall health standpoint. I'll go ahead and plug that. I'm not sure who's talking. Is it Dr. Chapman, by the way?
It's going to be Jay from the Sleep Center.
Super. Sleep is important. You spend a third of your life in sleep. Hormone fluctuations. So we know that women who have migraine, most of their attacks occur around the time of their menses. Now, I tend to have this sort of thing against regulating your hormones just to try to get your migraines better. I think that's kind of a backwards way of looking at things. There are other ways of doing so, but occasionally we do recommend some hormone manipulations. Fasting or low blood sugar, and then stress or even letdown from stress. So there are some individuals who have migraine when they go on vacation 2 or 3 days into it, so-called crash migraine. So it's let down from, presumably we're all working, we have some baseline level of stress, and then go to Disney World 2 to 3 days into it, and suddenly Mickey is, a horror movie or something. So tips for acute and preventive medication success. So for acute medications, more is not always better. So for acute treatment, typically not more than 2 or 3 days per week of use of an acute medication. So that's a goal to kind of get to. And then take only the doses prescribed. If medications appear not to work after treating 2 or 3 attacks, you call your doctor. So it's a separate issue. If you walk out of the office and you have a prescription for an acute treatment, you want to try that not just once, but maybe 2 or 3 times, as long as there are no side effects, to make sure that it's ineffective, and you can give that feedback then to your physician. Preventive medication tips, take as instructed, no more, no less. Give the medication time to work, 2 to 3 months. Track the headache pattern. That's the outcome that a physician needs in terms of a preventive medication in particular is a calendar or a diary of the headaches. So how do we recognize medication overuse? So taking acute medication for a headache becomes almost daily routine. So, behavior being what it is, occasionally I'll see people that are anticipating that they might have a headache, and then they'll take Excedrin migraine. Well, they don't really have a headache, but they might have a headache, so they take it, and they take it every day. So it's not addiction. I don't know what really constitutes addiction, but it's sort of anticipatory taking of something that's intended for as-needed relief. The medication appears to become less effective, so we tend to want more of it. So, people ask me, well, if I'm taking Tylenol 4 times a day for every day, is that going to damage my liver? Well, A, it might, but B, it's certainly is strongly associated with chronic migraine. So therefore we need to discuss a plan to not do so, or alternatives or different strategies. And then another notion is that stopping or slowing the medication may result in worsening of the headache. So I do see folks that are in kind of a rebound situation, usually tell them, we're going to do a different plan, but you're going to probably hate me for a couple weeks as you get kind of detoxified from all this. So why is it important to see the doctor regularly? So other problems can arise, or other illnesses. So medication overuse, we mentioned. Migraines can become difficult to control in certain situations, and to sort of make sure that the headaches aren't becoming worse. So, there are many reasons why I love what I do, but one of them is that it's a condition that I can sort of work with the patient, get it under better control, and then have them to transition back to their primary care physician. So not many neurologists are actually able to do that. Many of the conditions that we see are more chronic and not going to be taken care of by the primary care doctor. So don't be confused by the migraine myths. So the first is that it's all in your head. Well, yeah, it's in your head, but it's also biologic. So it's a biologic disorder with clear genetic links, and there are underlying changes in the brain. Everybody's looking for corroborative evidence. There is no corroborative evidence that an individual has migraine. It's really on historic grounds. We obtain imaging, we obtain maybe other testing for the purpose of excluding other conditions that cause headache, but there's no MRI, CAT scan, EEG, anything that's going to corroborate the migraine story. So by definition, it has to be a condition of active participation with your physician. Nobody understands my headaches. Well, the fact is about 1 in 4 households in the United States have at least one migraine sufferer. So if you look down the street, out of 4 households, at least one will have somebody who suffers from migraine, either adult or child. Another myth, nothing works to treat my headaches, it's hopeless. Actually, there's now very sophisticated migraine-specific medications. So triptans, for example, are considered to be relatively migraine-specific in the mechanism of action. So sumatriptan was the first one approved. It was approved in 1992, and yes, I was in practice then. And it took I was astounded when I heard the talk at a national meeting of how long it took to be developed, but it took a while for the actual mechanism of migraine to be developed, to be worked out, and then a medication to specifically treat migraine and specifically address the light, sound sensitivity, nausea, and vomiting. So this is a website that I mentioned. If you can remember nothing else, American Council on Headache Education, ACE, the actual web address, it's called a URL, is acenet.org. I think if you Google, well, you probably won't want to Google ACE, but if you Google American Council on Headache Education, actually if you just Google America and headache, and that's all you can remember, the American Headache Society is the overarching body that most headache specialists are members of. ACE is a sub-chapter of that. So that, if you just Google America and headache, then you can find the American Headache Society website, and then there's a link on there to ACE. But that's the education piece of the American Headache Society. So this is what the homepage looks like. And actually there's a whole education center. Actually, if you go to this is ACE, but if you go to the American Headache Society website, on the right is nothing but a big button to get to ACE, and it's called the Fred Scheftel Educational Library, And it has lots and lots of tools, information, headache diaries. There's something called MIDAS, the Migraine Disability Assessment Scale, other things like that. So it's a useful tool. So how much does migraine cost in the United States? And this is old data. This is 15 years ago, but back then the cost of migraine is estimated to be about $15 billion. So the direct costs are costs that we can measure. So we can measure physician visits, diagnostic testing, medications, emergency department and inpatient treatment. We can measure that directly, and that's about $2 billion. Indirect costs are harder to measure, and there are statisticians that are much smarter than me about statistics, but can measure things like absenteeism. Presenteeism means you're present, but you're not working as well as you should. So migraine is associated with cognitive dysfunction, difficulty thinking. And most people either, if they have chronic migraine or during or after an attack, will have some degree of just, I don't have the brain power today or what have you. So anyway, that's all I have today. So thank you. And I'll be glad to answer any questions.
Any questions?
What do you do when you're allergic to the tryptophan?
To the triptans. So there are other options. So, and it depends on the individual. So, non-steroidal anti-inflammatory drugs, if there's no contraindication, are probably the next line. Sometimes in combination with anti-nauseants. So the anti-nauseants actually address specifically the light, sound sensitivity, nausea, vomiting, and to some extent, in a migraine attack, can help with the pain component as well. So, so those would probably be the top lines. There's a few other situations, and it's hard to distinguish. What constitutes an allergy and what constitutes an adverse reaction.
Bad rash.
Well, then that's an allergy probably, as best we can tell. So there's no way to parse that out further. You just would say, well, I'm allergic to triptans. But yeah, you'd have to explore other options, I think. Yeah.
So with the preventative medications, do you see people that that their body just gets immune to those and they have to be increased over time?
Yes, we don't have a good explanation for it. Immune is, implies a specific allergic having to do with your body's defenses of certain conditions. We might use that excuse, but yes. So I do see individuals in whom a preventive medication sometimes just quits working and we need to change to something else. I don't think that that science understands that very well. If you do nothing but headache, which is what I do, then you see this, but you may not have a great scientific explanation for it. So it does help sometimes to just change a preventive strategy.